of Medicine, Rutgers Robert Wood Johnson Grand Rounds. I'm going to go ahead and pass it over to the Chief of the Division of Rheumatology, Naomi Schlesinger, in a second. But before I move on, I wanted to remind everybody that you'll be muted during the conference, but we welcome all chat and questions at the end. For any comments or questions you have during this, you can post it in the chat. And before I pass it on, I did want to announce that next week we have a very special Grand Rounds that we're sharing in conjunction with the New Brunswick Theological Seminary. It's a bioethics conference entitled Look on My Suffering and Deliver Me. It will be a wonderful interdisciplinary dialogue on the medical aid and dying law in New Jersey. Thank you, Dr. Schlesinger. Yep, you're muted.
Okay. Is this an order from above, the muting? Okay. So good morning, everyone. It's a great honor for me to introduce our speaker today, Dr. John Stone, Professor of Medicine at the Harvard Medical School, and Edward Fox Chair in Medicine at Mass General. One of really the pillars of rheumatology today. You know, when I reviewed his CV, which is over 115 pages long, it was interesting to see that he actually studied history and did a Rotary scholarship, was a Rotary scholar at Oxford in English literature. Only then did he go into medicine at Harvard and had a long career, had a fellowship at University of California after doing his residency at Johns Hopkins, joins Johns Hopkins, runs trials on vasculitis that are published in the New England, at Lancet, and so on. And in this phase, he joins in 2009. He joins Harvard and leads, again, trials in vasculitis, but also this emerging disease, IgG4, which he heads studies, heads conferences, really is the main authority today in the world at IgG4 disease. He has over 200 publications, as you can understand, in high-tier journals, many awards and accolades. As a visiting professor in 2007 at UMBJ in the New Jersey Medical School, and really lectures near and far, and millions of dollars in grants, and mostly from the NIH, and really a great honor for us to have someone of his caliber giving medicine grand rounds today. Thank you so much, Dr. Stone.
Naomi, thank you. Thank you for that very generous introduction. Thank you for that very generous introduction. It's great to be with you today virtually. Dr. Cohen, thank you very much for inviting me to speak. The picture of this young woman and her neck are the very first patient that I saw when very first patient with IgG4 related disease that I recognized. And she was one of the very first patients I met upon coming to MGH back in 2008. And the past 13 years really have been a wonderful ride in helping to identify this disease and understand its pathophysiology and develop new therapies for it. And one of the points that I want to make is that we've learned so much about this disease from individual patients. And that's been, I think, the greatest part of the journey for me. So I'm going to actually present to you over the course of my talk a series of patients, and through their stories, I will hope to teach you something about what we've learned about the pathophysiology of this disease. I will talk about the classification criteria that were published in 2020, emphasizing only the points of the classification criteria that are really important clinically. And then finally, I'll talk about the approach to treatment and emerging treatment options. So this, again, was a picture that I took of the young woman's neck. She was a 26-year-old woman from Casablanca. Casablanca has always been my very favorite movie, so I thought that was a little bit romantic. And in looking back on this now, I think it is remarkable that in 13 years, we've gone from picture of this patient's neck, I didn't know what I was looking at, to this picture, which is really a reasonably complete overview of the pathophysiology of the disease. And I'll come back to this as we go through the talk, but I would have you note that two cell types are really key. Cells of the B lineage, including B cells and plasmablasts, which we think are presenting antigen to a specific T cell, a CD4 positive cytotoxic T cell. And our group was the first to identify this CD4 positive cytotoxic T cell. Both of these cells contain on their surfaces a marker called SLAM-F7, and indeed they interact through SLAM-F7. So we'll come back to this as we move on, but we've made a lot of progress in just 13 years from insights gleaned from individual patients. So IgG4 related disease is not a new disease. I was trying to understand what was causing this submandibular swelling in my patient, and I came upon this paper from the German medical literature in 1892. And you can see that this patient, who was a 44-year-old German farmer, had enormous submandibular glands. Moreover, his parotid glands were huge, and his lacrimal glands were so big that he could barely open his eyes. So this was published in 1892 by a famous surgeon of the day named Johann Mikulicz. I remember learning about Mikulicz's syndrome in medical school. So this is a picture of my patient's neck, and in reading further in the literature, the other really intriguing paper was from the Swedish literature, and that was published in 1979, and it included this picture of this man's neck. You can see that he needed a shave. It's a man, and his submandibular glands look just like the submandibular glands of my patient. So I was really taken aback by that. And ironically, this patient, the first author of that paper in 1979, her last name was Sjogren. Not Henrik Sjogren, who described Sjogren's syndrome in the 1930s, but rather Ingela Sjogren. I guess Sjogren is a very common last name in Sweden. It's sort of like Smith, I guess, in the United States. Or maybe Ingela is related to Henrik, I don't know. But the title of this paper, talking about primary sclerosing cholangitis associated with fibrosis of the submandibular glands and the pancreas, really started me thinking that maybe I was dealing with a multi-organ disease in this submandibular gland swelling in my patient, and she had been referred to me to exclude Sjogren's syndrome. And once we began to become aware of IgG4 related disease, we realized that we had been following this patient in clinic with a diagnosis of Sjogren's syndrome for about 8 years. And he had dramatic enlargement of his parotid glands, as you can see here. And he had some features, however, that were unusual for Sjogren's syndrome. He had asthma, not a typical Sjogren's syndrome feature. He also had orbital myositis, by which I mean inflammation in his extraocular muscles, which help the eyes to move in a coordinated, yoked fashion. Also not seen in Sjogren's syndrome. And he had parotid enlargement, which is obviously very typical of Sjogren's. You can look at his picture here and you can see that he also had submandibular gland prominence. His Sjogren's syndrome had been refractory to steroids and to methotrexate, and we began to wonder whether he had another diagnosis. We checked his serum IgG4, and lo and behold, his serum IgG4 was elevated to more than 10 times the upper limit of normal. And looking back on his case now, I chuckle every time because I really should have recognized that this was IgG4 related disease, because I think you'll agree this patient looked exactly like the patient described by Mikulicz. I mean, the mustache is just absolutely identical in both patients. I've been accused actually of having this patient grow a mustache to look just like Miklich's original patient, but I swear I didn't do that. This is a picture that I took on the patient the very first day. I thought that I would never see such dramatic lacrimal gland enlargement as Miklich observed in his patient. After all, Miklich didn't have access to glucocorticoids or anything else that might be effective in treating inflammation, and I thought that they would just see a more advanced natural history of the disease. But not too long ago, I saw this patient who has enormous lacrimal gland enlargement, and this is a patient who walked around various Boston hospitals for a number of years, having biopsies of a variety of different organs before it was finally realized that she had IgG4 related disease and very prominent lacrimal glands. Now, you probably didn't learn how to examine the lacrimal gland in physical diagnosis in medical school, and you weren't examining very many, probably aren't examining very many lacrimal glands on your inpatient service now, but this is how you examine the lacrimal gland. You just gently evert the eyelid, and if the lacrimal gland is enlarged, it just pops right out. That's my thumb right there. And this is a drawing of Miklich's original patient. And I always thought it amusing that the artist describing the case by Miklich found it important to include a picture of the patient, of the examiner's thumb. I presume that that's Miklich's thumb examining the patient, and that's the lacrimal gland right there. So IgG4 related disease, as you will see, is a multi-organ disease, and the disease was recognized as a unique condition that we now believe is an autoimmune disease only less than 20 years ago in Japan. And Japanese colleagues came up with a wonderful metaphor for this disease. They described the disease as being like a crow flying through the dark night. Because I had been a rheumatologist for 12 years before I recognized my first patient, completely missed many others. The disease was there when I was in medical school and when Miklich was in medical school, and it has been missed for generations and generations. We don't know how far back, but we do know that over the last 15 years or so, this crow has flown into full light. And we recognize now that it is a multi-organ disease, making it a great disease to give medicine grand rounds on, because there is something for everybody in this disease. So I'm often referred patients for the question of, is this IgG4 related disease? And one of the very first question I ask myself is a typical organ involved? IgG4 related disease can involve any organ in the body, but there are really 10 to 12 that are typical. And these are the ones that are typical. So the pancreas and the bile ducts, the orbits, particularly the extraocular muscles, the lacrimal glands and the major salivary glands, by which I mean the parotid glands and the submandibular glands. Then the retroperitoneal fibrosis is usually IgG4 related disease. The lungs, kidneys, aorta, the pachymeninges, and the thyroid gland, particularly or specifically renal thyroiditis. Renal thyroiditis is IgG4 related disease of the thyroid gland. So if the patient doesn't have one of these typical organs, I question whether IgG4 related disease is the correct diagnosis. I don't care what the serum IgG4 concentration is. So the next patient I want to tell you about is Dr. 414, and he's actually a physician, and he, I think, taught us as much about IgG4 related disease as any patient so far. I first evaluated him back in December of 2012. This is a picture that I took of him on the day we first met. You can see he had parotid enlargement, submandibular gland, and sublingual gland enlargement. His left submandibular gland had actually been resected, and I will show you that pathology. But in addition to this major salivary gland involvement. He had multiple organs involved: pancreas, biliary tree, kidneys, pericardium, lungs, lymph nodes, and even his prostate gland was involved with his disease. And over the 3 years before I had met him, he had been misdiagnosed as having adenocarcinoma of the pancreas, multiple myeloma, and lymphoma. All of those were incorrect diagnoses. So these were his labs on the day we met. And you can see that he had an impressively high globulin fraction. Most of this turned out to be IgG4. He had more than 5 grams of IgG4 per milliliter in his blood. He was also profoundly hypocomplementemic. These complement levels really look like lupus nephritis or essential mixed cryoglobulinemia. The fourth complement component was not even measurable. And his serum IgE was also high, which we also see in IgG4 related disease in many patients. So Dr. 414 had brought his submandibular gland slides with him to clinic. And he actually lives in New York. And we walked with him to the surgical pathology department and sat down at the microscope with the pathologist and reviewed his submandibular gland. You can see all of the blue staining cells. These are inflammatory cells, and there's obviously some fibrosis through the tissue. This is a picture of the slide. I just held up the glass slide and took a picture of it. CD19 stain. The CD19 is a marker that is found on essentially all cells of the B lineage. So all of those brown staining areas represent concentrations of B cells. And this is a higher power view of the CD19 stain. And when you see this stain, you'll understand why we are now studying an anti-CD19 antibody approach to treating the disease. So CD19 is, this is a very quick primer on B cell development. B cell development begins in the bone marrow from stem cells. And then in the very earliest stage of B cells, CD19 is expressed. And CD19 expression continues throughout other phases in the bone marrow. And then B cells, as they're developing, migrate to the peripheral compartments, to lymph nodes, where they continue their development and learn to make very specific antibodies in response to specific antigens. CD19 remains present on these B cells throughout that time. CD20, which is the target of rituximab, is expressed a little bit later than CD19 and is lost a little bit earlier than CD19. So in 2012, I didn't have a CD19 antibody therapy to treat him with, but I did have rituximab. And because of the overwhelming nature of his disease, we treated him with B cell depletion right off the bat. So after rituximab, within 1 month, his globulin fraction had fallen dramatically, his complements had nearly normalized, and his IgE had plummeted. And these improvements were sustained despite the absence of any additional therapy following this rituximab treatment for many months. The hypocomplementemia resolved, and the IgE elevation also resolved. And the patient felt resurrected by the therapy, thought he was cured. His serum IgG4 continued to fall for a long time. This is 14 months. He's continuing to feel well, but his serum IgG4, although it's only 1/10 the level that it was at baseline, is still very elevated. And we'll come back to that when we talk about the importance or the lack thereof of IgG4 in the overall pathophysiology. But again, coming back to this primer on B cell development helps us understand why the serum IgG4 concentration falls but doesn't normalize. That's because there are certain plasma cells that are not CD20 positive, so they are not affected by rituximab or B-cell depletion therapy. And these plasma cells, which are long-lived, have migrated back to the bone marrow, and they will continue to make IgG4 for a long, long time. So our experience with Dr. 414 created our first hypothesis about how IgG4-related disease works and what is important in this disease. So the CD20 positive B cell seemed to be an important player in the disease. And CD20 positive B cells are all the time becoming IgG4 producing plasmablasts and short-lived plasma cells. These cells are doing what they do all the time. They're making IgG4, but they go away quickly because they're short-lived cells. That's okay as long as the B cell pool is still there, still intact, to replenish them, to replete them after they go away naturally. But if the B cell pool is gone because of rituximab or some other B cell depleting therapy, there's nothing to replete those plasma blasts and plasma cells, and the IgG4 concentration falls. And that's what we thought was going on early on. It turns out that this is true, but only part of the story. So this potential model that we developed held that B cells were critical to the pathophysiology of IgG4-related disease. And after rituximab, they were gone very quickly. And this led to a failure of repletion of the short-lived plasma cells and plasmablasts that make IgG4, and the IgG4 fell. That's what we observed. It seemed to explain what we observed, and that's what we thought was operative in this disease. So Dr. 414 did quite well, but he eventually flared. He went into remission again with another course of rituximab, and he flared again. And then about this time last year, he came out of remission again, his third or fourth flare. And with his flare about a year ago, his albumin fell, his globulin increased. This was mostly IgG4. His complements fell, his IgE and his IgG4 both rose. So I gave him rituximab. Again, we didn't have any active clinical trials. I treated him with rituximab. I thought he would do well again. This time, however, he felt awful. He did not improve with therapy. And he called me a few weeks after he'd been treated, and he said, this must be some adverse effect of rituximab. Have you ever seen this in a patient? He had weight loss. He had no energy. He had diffuse pain. And I said, I have not seen that, Dr. 414, as a complication of rituximab. I am stumped. You better come up so that we can meet in person and try to sort this out. So what was going on? I was completely perplexed. And after I saw him, I was still perplexed. And I thought, well, maybe he's become hypothyroid, and that's why he feels awful. His TSH was normal, but his T4 was virtually unmeasurable, which was puzzling because that meant that this TSH was not normal at all. It was strikingly abnormal because with a 0 T4, he ought to have a sky-high TSH level. So something was going on. The case breaker was this. His cortisol was also unmeasurable. And so what this meant, it implicated a central etiology to his hypothyroidism. And he had pituitary gland failure, IgG4-related hypophysitis. And you can see his pituitary gland here is swollen. It's enormous. This is the pituitary gland. And unless you're an endocrinologist, you don't look at pituitary glands very much, but I can tell you this is a huge pituitary gland. And when you think about it, it makes all the sense in the world that his pituitary gland would be involved as well. After all, IgG4-related disease has a tropism for glands: the parotid gland, the submandibular gland, the lacrimal gland, the pancreas, which is a gland. And I surmise that his pituitary gland was involved the entire time. From day one, back in 2012, the first day I met him, his pituitary gland was involved. It was just subclinical because not enough of the gland had been destroyed. And with each subsequent flare, more and more of his pituitary was involved until he presented with profound hypopituitarism. So hypophysitis leading to pituitary failure. I can tell you the experience of managing this patient has taught me that it's very difficult to live without a normal pituitary gland. And even after treatment, he has not recovered full pituitary function. There's been some improvement, but still not 100%. It's very difficult. So I go through Dr. 414's case in some detail to emphasize the cumulative damage that occurs in IgG4 related disease. So the most important damage, the most common damage that occurs in this disease is pancreatic failure, both endocrine pancreatic failure and exocrine pancreatic failure. Yesterday, I saw a patient who became another physician, incidentally, who became an insulin-dependent diabetic at the age of 59, and several years later developed exocrine pancreatic failure before his underlying disease was recognized. Now, this is the poster child of a patient with exocrine pancreatic failure, which is really more common than endocrine failure. The exocrine pancreas makes digestive enzymes, and without a functioning exocrine pancreas, patients cannot digest food, they can't absorb calories, and they lose prodigious amounts of weight. They have low levels of amylase and lipase in the blood. They have unmeasurable fecal elastase measurements in the stool, and they require pancreatic enzyme replacement with every meal, creon and other things like that. So the probably 40 or 50% of patients in our clinic have endured a major hit to their pancreas. Exocrine pancreas more common than endocrine pancreas, but kidneys can also fail. These patients can develop retroperitoneal fibrosis, leading to the need for chronic indwelling stents. I'm seeing a patient later this morning who has had stents in for years before we treated him successfully. Sometimes the liver can fail as a result of the biliary disease. Orbital lesions can lead to diplopia and vision problems, and the pituitary gland can fail. So there's a consistent histopathology across all of these organs. This is the submandibular gland biopsy of my very first patient. And these patients, organ after organ, show lymphoplasmacytic infiltrate, a fibrosis. You can see the swirling fibrosis through the tissue, which has a name called storiform fibrosis. Storiform is from the Latin word storea, which means woven mat. And the third key histopathologic criterion is obliterative phlebitis. And right here, you probably can't appreciate it. That was a vein. And the same lymphoplasmacytic infiltrate just moved right through the vein and destroyed it. And the elastin stain would show the completely destroyed venous wall. IgG4 related disease is also associated with germinal center development in organs that are involved. So the development of tertiary lymphoid organs at sites of disease, extranodal germinal centers. This is a submandibular gland biopsy. One shouldn't have germinal centers in a normal submandibular gland. This is a picture, a slide of meninges, a meningeal biopsy from a patient with IgG4 related hypertrophic pachymeningitis. And you can see the same swirling storiform fibrosis in the tissue enmeshing this lymphoplasmacytic infiltrate. And this is a pancreatic biopsy. It's a resection sample. It's not a biopsy. It's a resection of the pancreas, a modified Whipple procedure. You can see the pancreatic duct here. This patient was thought to have adenocarcinoma of the pancreas because the disease so often presents with mass lesions. And the pancreas, which I think you'll agree is a very different organ from the meninges, looks just like the meninges when it's affected by IgG4 related disease. Storiform fibrosis enmeshing this lymphoplasmacytic infiltrate. The kidneys can also be affected. We know we're in the kidney here because of the glomerulus, and you see the fibrosis throughout the tissue. And look at all the eosinophils, lots of eosinophils, these pinkish staining cells. This is also a minor feature in many patients with IgG4 related disease. So a large proportion of the plasma cells in these biopsies are IgG4 positive. This is a kidney biopsy, and what pathologists do is they stain one slide for IgG4. All of those brown staining cells are IgG4 positive plasma cells, and they also do an IgG stain. And although there's a lot of background noise in the IgG stain, there always is for some reason. If you look carefully, you see the brown staining IgG4 cells, I'm sorry, IgG cells, right where you see the IgG4 cells. So I would guess that 60% at least of the plasma cells in this sample are IgG4 positive, and that's a strikingly high IgG4 to IgG ratio. But IgG4 has been overemphasized in this condition. So IgG4, you will recognize here that this is a schematic of a typical antibody, is what we learned in medical school. And that was about the level of sophistication of immunology that I learned in medical school. But these are both representative, different immunoglobulin levels. IgG4 is different from the other IgG subclasses. There are 4 IgG subclasses, 1, 2, 3, and 4. But IgG4 is different from the others because it literally becomes unhinged in its hinge region, and half of the 2 halves of the antibody come apart, and it recombines in serum with another IgG4 antibody. It's the only IgG subclass that does that. This process is called FAB arm exchange. The impact of this, the upshot of this FAB arm exchange, is that IgG4 antibodies are asymmetric. They have FAB fragments that are different, and they don't bind antigen very tightly compared to other immunoglobulin subclasses. They've always been viewed as wimpy antibodies, and this is probably why these antibodies are elevated. We think that IgG4 is playing a counter-regulatory, down-regulatory role, perhaps going into sites of inflammation where the primary process is going on and trying to soak up antigen without inciting additional inflammation. So IgG4 levels continue to rise in the blood until effective therapy is administered. IgG4 levels are helpful in diagnosis if they're high. They're helpful in monitoring if they're high at baseline. But IgG4, we are now quite convinced, doesn't cause IgG4 related disease. We think these antibodies are playing a counter-regulatory role, and I'll say more about that primary response in a moment. We do know, however, that IgG4 is elevated in only about 3/4 of patients before they start treatment. But if the IgG4 is very elevated at baseline, it's a marker for a disease, for a patient who's going to have recurrent disease and probably should be treated with something other than just steroids from the very beginning. So this was a study we published several years ago of 125 patients from our center who were in remission following treatment. They all started in remission up here. And we analyzed them according to their baseline quartile of serum IgG4. Those in the lowest quartile had the lowest risk of disease flare in this survival curve. But those in the highest quartile of serum IgG4 at baseline were much more likely to flare. And in fact, their hazard ratio for flare compared to those who had low serum IgG4 was 6.2. So high IgG4 is a marker for typically multi-organ disease and a patient who's going to flare over time. So this patient helped us put together the next big piece of the pathophysiology. She's got parotid enlargement that you can see here. Submandibular glands also big. You can also often feel them more than you can see them. And she had proptosis. Proptosis is caused by swollen, enlarged extraocular muscles, which push the eye out. And she also had IgG4-related disease of the skin. Indeed, the diagnosis of IgG4-related disease had been made on biopsy of these papules on her cheek. She'd been treated for months with steroids. She said, the prednisone has done nothing except make me fat. I'm not taking it anymore. So we decided to treat her with something else, and we chose rituximab. But this allowed us to do an experiment in reverse. So we treated her with rituximab, and 5 weeks later, her condition overall was improving dramatically, and this is her skin only 5 weeks later. And we performed a follow-up biopsy right here where the previous biopsy had been done, and we compared it to her old biopsy. And what we found was fascinating. So this is the H&E of her skin biopsy at baseline before she was treated. You can see the epidermis up here, and there is inflammation throughout the full thickness of the dermis. Now, this is a CD3 stain, which stains CD4 positive T cells. So there, in addition to all the CD19 positive B cells that I showed you earlier, there are also a lot of T cells in the tissue in IgG4 related disease, CD4 positive T cells in particular. So this is the before H&E, and this is the after H&E. After rituximab, you can see that only 5 weeks later, we've managed to deplete the tissue of a lot of this cellular inflammation. And if we look at the CD3 stain before and after, I think you'll agree that after a targeted therapy that only hits B cells, CD20, we've managed to deplete the tissue of a lot of CD4 positive T cells, illustrating very strikingly the connection between B cells and T cells in this disease, and I submit in other diseases as well. So we began to look more carefully at T cells in this condition. And we did so through flow cytometry and next generation sequencing of T cell receptors, of effector CD4 positive T cells, and very quickly through next generation sequencing of patients' peripheral blood, we identified an almost monoclonal elevation in a certain CD4 positive T cell. And this T cell is not actually a monoclonal response, but it is highly oligoclonal. Typically, patients have 4 to 8 clonal expansions of this subset. This T cell makes unusual cytokines, interferon gamma, interleukin 1, and TGF-beta. All of these you will recognize can contribute to the fibrosis that's associated with IgG4-related disease. And this T cell makes other unusual products as well, including perforin and granzyme B. And it has surface marker previously undescribed on T cells, or at least CD4 positive T cells. And I mentioned that earlier, and that's SLAM-F7. So this experience with this patient caused us to rethink our model of pathophysiology, which originally held that B cells were central to the pathophysiology, and after they went away, plasma cells and plasma, short-lived plasma cells and plasmablasts weren't repleted, and IgG4 fell. But the B cell depletion had an effect not only on cells of the B lineage, but also on the T cell compartment. And the loss of T cells in tissue, which we assume is because of absence of continuous antigen presentation from B cells, leads to this resolution of the cellular infiltrate and the very rapid shrinkage of involved organs. So this is the critical cellular interaction we assume These B cells are presenting antigen, probably more than one antigen, although maybe only one antigen for each patient, to this CD4 positive cytotoxic T cell. And these cells in return are secreting the mediators that lead to fibrosis. So before we get into what all this means for treatment and I sum up our current therapeutic approach, I want to say a few words about how we actually get to the diagnosis and the classification of IgG4 related disease. So when you're approaching any disease in clinic, and it doesn't matter whether it's a rheumatic disease or not, you really have to fall back on information from four spheres: the clinical sphere, the history and the physical examination, any sorts of blood tests that may yield insights into the disease, radiology findings, and pathology. None of these typically is able to make a diagnosis by itself. In oncology, you can make a diagnosis with just the pathology findings. Not so in the rheumatic diseases, not so in immune-mediated diseases. Our diseases are symphonies of inflammation, and we have to put together information from all of these spheres in order to make a diagnosis. So this was the principle behind the development of our classification criteria for IgG4-related disease. Information from each of those spheres was used: clinical, serological, radiological, and pathological. The effort of developing these criteria involved almost 100 investigators from 5 continents across the world, 1,900 patients, more than half of whom had IgG4-related disease, and another 800 of whom had mimickers of IgG4-related disease. I'm not going to go through in great detail how we did this. I just want to impart to you the important clinical lessons that we learned, but we used a process called multi-criteria decision analysis. So just a few points about what we learned from this classification criteria effort. I've already shown you this slide. The first requirement is the patient has to have a typical organ involved in order to be classified as having IgG4-related disease. And these are the typical organs. I've shown you pictures of most of these. If the patient doesn't have one of these typical organs, you really can't classify them as having IgG4-related disease. Second, the classification criteria had exclusion criteria because there's so many potential mimickers of IgG4-related disease. And there are very important lessons to be gleaned from these exclusion criteria. So with regard to the clinical exclusion criteria, if the patient has fever as a major component of their presentation, it's not IgG4-related disease. IgG4-related disease is an indolent disease. It is not a febrile illness, unless there's some secondary infection in the biliary tree, for example. But IgG4-related disease does not cause fevers. Similarly, if the patient has not responded to a generous course of steroids, it's not IgG4-related disease. With regard to serologies, if the patient is ANCA positive with specificity for proteinase 3 or myeloperoxidase, or if the patient has anti-Rho or LA antibodies, then the patient likely has ANCA-associated vasculitis or Sjogren's syndrome, respectively, not IgG4-related disease. With regard to radiology, the key feature is not any specific finding, but rather the rapidity of progression. IgG4-related disease is a slow, indolent disease. If you're seeing striking radiologic changes in 4 to 6 weeks, that's another process. That's a malignancy, that's an infection, it's vasculitis, it's not IgG4-related disease. And then finally, with regard to pathology, all the time we receive pathology slides. It's why we always review biopsies that our patients have had. If one sees a prominent neutrophilic infiltrate, not IgG4-related disease. Necrosis or necrotizing vasculitis, that's another process. And granulomatous inflammation, that's sarcoid, that's TB, that's granulomatosis with polyangiitis, not IgG4-related disease. So these criteria in summary work very well. We performed 2 validation cohorts, one of 900 patients, very excellent test characteristics, and a second independent validation cohort confirming these excellent test characteristics. So these are now used in our ongoing clinical trials and studies of this disease. So very quickly, I want to wrap up by telling you what we do for treatment now, standard treatment and investigational therapies that we are studying. Steroids remain the cornerstone of treatment across the world. And I've already indicated that patients with IgG4 related disease universally respond to steroids. So the typical approach in Asia, in Japan, in China, and Korea is to start the patient on 40 milligrams of prednisone a day, to taper them to 5 to 10, and then to leave them on that dose indefinitely. You can imagine that leads to a lot of steroid toxicity. And despite that, we still see, in Asia, they still see a high percentage of patients who flare. In North America and Europe, we've been a little bit more sparing of steroids, still starting at 40 milligrams a day, but attempting to taper the patient off over 8, 10, or 12 weeks completely. We see lots of flares when we do that, sometimes even before patients are off steroids. So there's clearly unmet need in this disease. And we're doing 3 clinical trials now, all are multi-center trials. And these trials are based on what we've learned about the pathophysiology. So 2 of the trials target B cells. So inebilizumab is an anti-CD19 antibody now approved for use in neuromyelitis optica. And I showed you the slide earlier from Dr. 414's submandibular gland biopsy and his submandibular gland packed with CD19 positive B cells. I think this therapy is going to work for this disease. We've enrolled 13 patients in this trial at our center alone over the past few months. The second B cell directed therapy is rilzabrutinib, which is a BTK inhibitor. That is a trial also going on in the United States and Canada. And then finally, taking advantage of this SLAM-F7 marker present on both B cells and the CD4 positive cytotoxic T cell, we are conducting an NIH-funded trial of elotuzumab, which is an anti-SLAM-F7 antibody. Elotuzumab was the first drug given a breakthrough indication for any disease by the FDA back in 2015. So we'll likely enroll our first patient in that trial as early as next week. So I want to summarize here in conclusion. IgG4 related disease is a great mimicker for our century. It's a disease that no one recognized as being a unique condition until the aughts, less than 20 years ago now. It's caused by a symphony of inflammation, and we've identified many of the individual musicians in this symphony, and now we're targeting them. The disease has a subacute evolution, and it's very responsive to treatment. This subacute evolution is the reason there is major damage that occurs. That pancreatitis, which ravages the pancreas, is not like alcoholic pancreatitis, highly symptomatic. It's very often subclinical. And that's why the disease can trash an organ even before the disease is diagnosed. IgG4 related disease is a great human model for studying human immunology. And I believe there are more discoveries and better treatments on the way soon. So with that, I would like to thank you very much for your attention, and I will be delighted to answer any questions if there are some. Thank you.
Wonderful. Thank you so much, Dr. Stone. That was fantastic and interesting and eye-opening for myself as an endocrinologist. I mean, I've had patients with Hashimoto's hypothyroidism that later went on and found to were discovered to have IgG4 related disease, and it was presumed that they were, part of the same condition, because I know that Hashimoto's is frequently seen in patients who have hypothyroidism from IgG4 related disease. And so it makes me think about, how many patients are we missing who we diagnose with other conditions, especially something as common as Hashimoto's hypothyroidism. And we presume that this enlarging goiter and the Hashimoto's, the elevated TPO antibodies, is all just part of Hashimoto's. It makes me think of patients who have Graves' disease with ophthalmopathy. Are both of those just related to IgG4 disease? And it makes me also think about trials that we've looked at for underlying treatment of Hashimoto's and Graves' disease, which have shown mixed results with rituximab and with steroids. And maybe those subset of patients that respond to them are actually just IgG4 disease and not simply Graves' disease or Hashimoto's. So I guess maybe my mind is exploding and I'm not sure where my question is, but when should we be exploring this possibility of underlying IgG4 disease and alternative treatments instead of just treating the inflammation?
So that's a great question. And I would come back to one of the slides I showed early on and emphasize that in order to suspect IgG4 related disease, the patient has to have a typical organ involved. And if the patient's got extraocular muscle involvement, then that's a typical organ. And it may well not be Graves' orbitopathy, but rather IgG4 related orbital disease. So is there a typical organ involved? Has there been an indolent presentation? Does it present, has the patient presented with a mass lesion? This disease so often mimics cancer. I must have 30 or 40 patients who've undergone modified Whipple procedures because it was thought that they have pancreatic cancer. As recently as 2 weeks ago, we had a patient at my hospital who had a modified Whipple procedure for what turned out to be IgG4 related disease. You know, the surgeons really should have gotten that message by now. So that's when I would think about it, when there is a typical organ, when it's been an indolent type of presentation, and if there's a mass lesion, and if there's elevated globulin fraction, if the globulins are elevated over out of the range of normal, then that requires some further investigation with IgG subclass evaluation.
Great, thank you. There is a question about, a couple questions about, well, a few questions about therapies. First one is the question about use of tamoxifen. This individual has heard that there's benefit from using tamoxifen in patients who relapse despite steroids.
Right. So tamoxifen is a therapy that's been put forth in retroperitoneal fibrosis in particular. And long story short, without sort of diving into the paper that purported to show its effectiveness in the Lancet a decade or so ago, tamoxifen is not a great therapy for IgG4 related retroperitoneal fibrosis. Steroids are much more effective, and B cell depletion is very effective as well. Because of the entrenched nature of the fibrosis and the likelihood that patients would need long-term high-dose steroids, I tend to use B cell depletion therapies. And it's also possible that some of the therapies we're studying now will be effective. But tamoxifen is not something that I use. It's interesting that patients can have excellent clinical responses, even if radiologically the response is not dramatic, even if the fibrosis doesn't melt away following, say, B-cell depletion or prednisone. Just a little bit of shrinkage of the retroperitoneal inflammation can lead to great clinical improvement. And the retroperitoneal fibrosis has a very distinctive pattern. It's usually periaortic and infrarenal, extending down to the iliacs. If you see that, it is very likely IgG4 related retroperitoneal fibrosis.
Wonderful, thanks. So we have lots of questions here. We'll try to get through them and get you to your busy clinic. Are there reasons to think that any of these new therapies would have a better safety profile than rituximab?
Yeah, so the anti-CD19 therapy that we are testing inebilizumab is a humanized antibody. So rituximab is a chimeric antibody. So it's more likely to be associated with serum sickness reactions and infusion reactions. Inebilizumab has so far a superb safety record in its trial in IMO. It was tolerated very, very well. And so far in our randomized trial, we've not seen any infusion events, although we don't know which patient is getting what therapy at the moment. The BTK inhibitor also has a very good side effect profile so far, and elotuzumab, the anti-SLAMF7 monoclonal antibody, is approved for use in refractory multiple myeloma. So those patients are very sick and a lot sicker than a typical IgG4 related disease patient, and they get a lot of other potentially toxic therapies, yet elotuzumab is tolerated quite well. So it will also, our trial is also not designed to use the drug as long as myeloma patients receive it. So just 4 or 8 doses, I think, will be tolerated very well.
Great. What is your practice for relapses despite low-dose steroids?
I would go to another agent at that point. I'd like to enroll those patients in trials whenever possible, but if not, none of the conventional immunosuppressive agents, methotrexate, Cellcept, azathioprine, none of them really works that well. So I would use B-cell depletion if the patient can't get into a trial.
Okay. Are there other associated immune-mediated diseases? What underlies the idiopathogenesis, genetic, environmental risk factors, et cetera?
It's a great question. The genetics of the disease are still not well studied. There has been a GWAS done that was really not big enough to have great power and only identified a couple of genes, a couple of loci in the HLA region. We have been more effective so far at identifying potential antigens that may trigger the disease. Our group, for example, identified galectin-3 as an antigen that may be the triggering antigen in at least some patients. And other groups have identified other antigens. I don't think there's just one antigen that triggers this disease. But a good story is now being made that IgG4 related disease is an autoimmune disease. And we don't know how to account for the loss of tolerance to certain individual antigens, but it does seem to be an autoimmune disease. Unusual among autoimmune diseases in that it tends to affect male patients rather than female patients who are middle-aged, elderly. So not classic autoimmune disease patients, but this does seem to be an autoimmune disease. Much to be learned still about pathophysiology and ultimate etiology.
And just as a follow-up to your comment about it being potentially an autoimmune disease, how do pregnant women with IgG4 disease, how does their disease do during pregnancy?
Great question. The experience in pregnancy is very, very small. The reported experience is very small. I'll tell you an anecdote that from only this week. I got an email from colleagues in England asking me how to treat their patient who was pregnant with IgG4 related disease and had a very aggressive disease of the nose, causing bone destruction and sinus destruction and destruction of the roof of the mouth. And I said, that doesn't sound like IgG4 related disease to me. Could this be cocaine-induced midline lesion, midline destructive lesion? And indeed, that's what it was. So I mentioned that anecdote to highlight our dearth of knowledge about what happens to IgG4 related disease in pregnancy. We don't really know, but to also underscore the point that aggressive, destructive, rapid disease is very atypical of IgG4 related disease. And So that was an important point. The only therapy that's going to help that patient stopping cocaine.
And on that note, maybe
hopefully we'll know more about your underlying question soon with more experience with pregnant women. My sense is they'll do well and that they can be treated with steroids through pregnancy and hopefully wouldn't require really high doses. So I think confronted with that, I think we could get the patient through pregnancy safely. It would be best to avoid B-cell depletion therapy in a pregnant patient because of the potential impact on the immune system of the baby.
Great. Well, thank you so much. Wonderful. This applies to everybody, every single one of us, whether we're in general medicine or subspecialists. It's a fantastic talk, and it makes us think a lot about how we can take care of our patients and when we might be missing it, and making sure our patients aren't using cocaine during pregnancy at the same time. Thank you again for today.
Great pleasure. So nice to meet you. Thank you for the invitation to speak. Thank you so much, Dr. Schlesinger.
Thank you.